You're an orthopedic resident and it's a Friday afternoon in the emergency department. A 22-year-old fell on an outstretched hand. X-rays are negative, but they're tender in the snuffbox. You're tempted to call it a sprain and send them home. Stop right there. That negative X-ray is the most dangerous trap in hand surgery. Missing a scaphoid fracture isn't just a clinical error, it's a fast tracking to scaphoid nonunion advanced collapse and a lifetime of wrist pain for your patient. Today, we're mastering the vessel of the carpus. We're going from anatomy and blood supply to the Herbert classification and the surgical pearls you need for a perfect percutaneous screw. 80% of the blood supply comes from the dorsal carpal branch of the radial artery. It enters at the dorsal ridge and flows retrograde. Now, why does this matter in the OR? If you have a fracture at the proximal pole, you've just cut off the only grocery store in town. That's why proximal pole fractures have a massive risk of avascular necrosis. Everybody knows the snuffbox, but as a resident, you need to be more specific. And that's why you need the triple threat exam, which consists of anatomical box tenderness, scaphoid tubercle tenderness, palpate on the volar side, and you need to perform a scaphoid compression test, which basically means you have to apply axial pressure through the thumb metacarpal. If all three tests are positive, and with a negative X-ray, patient goes into a thumb spica and comes back in 2 weeks for a recheck or an MRI. Don't just order a wrist X-ray, you need the scaphoid view. This elongates the scaphoid so you can actually see the wrist. If you're still suspicious, MRI is your gold standard. It's the most sensitive for occult fractures within 24 hours. Let's look at the Herbert classification. Type A, which is stable. These are your tubercle or incomplete wrist fractures. And conservative management usually wins here. Then we have type B, which is unstable. This is where you call the attending. Complete wrist fractures, communications, or any displacement more than 1 millimeter, these usually get a screw. Now you're in the OR. Do you go volar or dorsal? Volar, also known as the FCR approach, best for wrist and distal pole fractures. It's great because you avoid the main blood supply on the dorsal side. Then we have the dorsal approach, also known as the EPL-EDC interval. Mandatory for proximal pole fractures. You need a direct line of sight to get that screw centered in the small proximal fragment. Now here is a high surgical tip. In percutaneous fixing, your starting point is everything. Use a trapezoid to scaphoid trajectory. If your K-wire isn't perfectly centered, your screw will cut out, and you'll be looking at a non-union in 6 months. Scaphoids are small bones with big consequences. Respect the retrograde blood supply. Never trust a single negative X-ray, and when in doubt, MRI is always key. If this helped you prep for your next hand call, hit that like button. In the next video, we're breaking down snag versus slack wrists and when to pull the trigger for a 4-corner fusion. Now tell me, what's your preferred image for suspected scaphoid? Are you an early MRI person or wait and repeat X-ray person? Let's argue about it in the comments. See you in the next one.